Welcome to the Metabolic Link, a medical and science-focused podcast that explores the common thread of metabolism in health and disease. This is where science meets society. Welcome to the Metabolic Link podcast. I'm your host, Victoria Field, and I'm the co-founder of Metabolic Health Initiative, which is the overarching organization to this podcast, to the scientific conference, Metabolic Health Summit, and to the medical education platform, the Metabolic Initiative, which is an amazing resource dedicated exclusively to metabolic health and therapy. Today, we're taking a deep dive into the ever-evolving landscape of cancer metabolism with a very special guest who's at the forefront of this research. Dr. Tomás Duraj is a physician and postdoctoral researcher working in Dr. Thomas Seyfried's lab, where he's really pushing the boundaries of our understanding of cancer as a metabolic disease. With a background in both clinical medicine and molecular biology, Dr. Duraj is uniquely positioned to bridge the gap between the preclinical research and real-world therapeutic applications. In this episode, Dr. Duraj joins my fellow co-host, Dr. Dominic D'Agostino, to discuss his groundbreaking review on ketogenic metabolic therapy for glioblastoma. And this is a paper that really brought together leading experts in the field to explore how metabolic interventions could truly revolutionize cancer treatment. We'll unpack the bioenergetics of cancer, the role of mitochondria, the Warburg effect, and the crucial question: can targeting glucose and glutamine metabolism make standard cancer therapies more effective? This is a must-listen conversation for anyone who's interested in the cutting edge of cancer research, the clinical potential of metabolic therapies, and how we might rethink the way we approach treatment. But before we dive into this episode, I just want to say thank you for supporting the partners of this podcast, and especially here for this episode. That's Fatty 15, Mudwater, and Puri. Our sponsors really make this kind of content possible, and we honestly believe in every single brand we work with. So we truly appreciate you engaging with them, visiting their websites, because the more you engage with them, the more we can bring this content on metabolic health and therapy to you. So thank you so much for listening to the ads in this episode. I also want to quickly mention that Dr. Tomás Duraj is actually joining us on our medical education platform, the Metabolic Initiative, on February 27th at 10 a.m. EST. You won't want to miss this because he's going to be answering all the questions you have after listening to this episode on cancer as a metabolic disease. Head on over to membership.metabolicinitiative.com/Duraj. That's Duraj. It's Duraj. So membership.metabolicinitiative.com/Duraj, and sign up for that because you won't want to miss the opportunity to engage with him one-on-one, and your first 7 days are completely free. So let's get into it. Here is Dr. Dominic D'Agostino's interview with Dr. Tomás Duraj.
Dr. Tomás Duraj, thank you so much for joining us on the Metabolic Link podcast. As you know, I've been wanting to get you on or Dr. Seyfried on, but especially you because you're the author of a recent review that we'll be talking about. And just want to say thank you so much for joining us on this podcast discussion today.
Well, thank you so much for having me. I'm a big fan also of your work, of the podcast that you do and everything, and long time listener, first time caller.
Yeah.
But
Well,
yeah, it's a great honor.
I feel honored to get you on because I know you're so busy in the lab doing things that you don't do a whole you do education outreach, you go to conferences and present at scientific conferences and things, but I really feel it's an honor to get you on, the podcast here. And a lot of people maybe don't know your background, including me. I don't know. I know some of it, but I think maybe we could start off by kind of sharing with our listeners here or viewers here on YouTube what your background is and how you got steered into this direction and specifically ultimately ended up in Dr. Thomas Seyfried's lab.
Sure. Yeah, so I'm a physician. I'm a medical doctor. I did my studies in Madrid in Spain, and this is like a 6-year program. And then I was a little bit disillusioned with clinical approaches to not only to cancer but most diseases. So I sort of pivoted a little bit and started a PhD in molecular biology, basically. So it's basically starting from scratch because, as you know, most clinicians, so like MD PhDs, when they do research, they don't always do like bench work or lab work. So I did my PhD in cancer metabolism and glioblastoma stem cells at the group of Dr. Ángel Ayuso Sacido in Madrid, also at the Universidad CEU San Pablo. And after that, I did sort of like a short stay, international short stay at the Seyfried lab, and I liked a lot. I was like a big fan of his work also, even before starting med school, really. So I was offered a position there as a postdoc, as a postdoctoral research fellow, and I joined the team. And what I'm trying to do is really to bridge the gap a little bit between um, all the preclinical lab work that they do on the basic science, which I also like, to be honest, perhaps more than the clinical sometimes, because it's so much more controlled, and you can kind of geek out on all the pathways and the variables. But really, the translational aspects are lagging behind a little bit in some of the things we do, and so I'm trying to bring it more to the translational, and to kind of direct based on what we know about the biology and the evolutionary biology of cancer and cancer metabolism and mitochondrial metabolism and the basic requirements of cancer cells in terms of their bioenergetics. Try to bring that into designing, approachable, feasible therapeutic strategies that people can implement. Some of them, dietary ketogenic metabolic therapy, people can implement easily right now with support of a dietitian, and building up to that with repurposed drugs or targeting metabolism with different drugs that requires a little bit more work in clinical trials. So we are trying to pool our resources together to also initiate that aspect, and bring it forwards.
Mm-hmm. Can you remind me when you started, what year? I'm trying to put it in the context of I reached out to Thomas Seyfried in 2009, I think, 8 or 9, and then we officially collaborated maybe 2010. So I'm trying to put it into that context of when, yeah, you started
Sure,
working.
sure. I am a little bit more recent addition. I did my first stay there in 2021 and then joined in 2022. So it's been like 2 to 3 years right now.
Wow, you've done a lot of work in that amount of time. Yeah.
Yeah,
Yeah.
well,
And the
I worked
presentations
on
I've seen,
this,
yeah.
yeah, presentations, and so in the lab, I'm working so I do bench work. I work with preclinical models with animals too. I don't do like a clinical practice out of Boston College. We don't do that. So I'm working on trying to characterize and compare. One of the problems that we have in most of cancer metabolism research is that we never have like an internal control of a normal cell in our studies. So what I'm actually doing in my day-to-day is comparing some of the models that we have, the CT2A and BMM3, these glioblastoma or glioma, malignant glioma cancer cells, from the mouse cell lines, trying to compare them with normal mouse cell lines and seeing the comparisons, the functional comparisons and the differences between cancer cells and normal cells, kind of interrogating what fuels and what bioenergetic pathways they can use. And this is work in progress. Been a little bit overwhelmed with as you've seen my paper, this one on the clinical side, it kind of ballooned out of proportion, and it's very long and very atypical. So with my project, also a little bit very broad, trying to compare everything. But I think it will be very interesting, and it will answer some of the questions that we always get asked about, like, well, can a cancer cell use a ketone body? Can a cancer cell use fatty acids or lactate? And when you start stripping away all the possibilities and trying to see really what is essential and what is sort of like an addition after the ATP sufficiency or the requirements for viability have been met. So that is sort of my my other life in the lab, working on the bioenergetics.
Yeah, that's really interesting because it's, sometimes it's put into context, just, restrict the cancer, just, take the glucose and the
Yeah.
glutamine from cancer cells, and that's how you kill
People
them, but
forget
you can also kill the patient.
there is a patient attached to the tumor. Yes.
Yes. Yeah, yeah. So, yeah, our original the differential response to hyperbaric oxygen, well, beyond hyperbaric oxygen of normal cells to cancer cells got us down. But you're right. I mean, we really need to use the control normal cells. Let's take a step back and maybe talk a little bit about cancer as a metabolic disease, like a short summary of that, and maybe arguments too against the general consensus in the cancer biology community of cancer as a genetic disease, or perhaps maybe an epigenetic disease too. We're looking.
Yeah. Yeah, I feel these terms, even ours, saying cancer is a mitochondrial metabolic disease versus genetic disease, these are a little bit of oversimplification. So people get a little triggered or angry when they hear that. And of course, it needs to be explained in a nuanced way. If you have seen in the paper, I don't really go into in detail into like cancer as a genetic disease. I do mention it, and I refer to Dr. Seyfried long work in this field. But I suppose that it might have been a hard pill to swallow for most clinicians. This was written for clinicians or dietitians or even patients. So getting into the background might have been too much. So I focus there on cancer bioenergetics. In terms of cancer as a metabolic disease, so what we believe based on the evidence that supports this is that really I would say like mitochondrial metabolism seems to be central in mediating as a primary cause, as a primary factor in malignant transformation, or for sure something in the cytoplasm based on the nucleotransfer experiments. So the question is, if you inherit a germline mutation, for example, that would predispose you to cancer, which is a very high risk factor, or if you just acquire somatic mutations in P53 or KRAS or any other gene, if this is necessary and sufficient for malignant transformation. And we would say no, it's mitochondrial reprogramming or mitochondrial damage or loss of efficiency in ATP synthesis, focusing more on respiration or oxidative phosphorylation, but also looking at the bioenergetics, so at the ATP, at the available energy that the normal cell has, as it starts to lose this efficiency in generating ATP, mainly. Of course, mitochondria do many other things in biosynthesis, etc. So as there is a gradual loss of ATP synthesis capacity, this triggers the malignant transformation. So this is the primary signal for the cell to, as you say, epigenetically, to start behaving as a cancer cell. And of course, yeah, mutations are a secondary downstream effect of this, so they eventually accumulate. And at the end, if you have a malignant cancer, it might be difficult to disentangle which was the primary, which was the secondary. But we would argue that for sure, it looks like if you were able to restore or switch up the mitochondria, it might be through different mechanism, maybe through a blockade of signaling or through some incompatibility. But if you were able to restore normal oxidative phosphorylation, that phenotype, despite the mutations, that phenotype would either disappear or the cancer cell would maybe undergo apoptosis if the oxidative phosphorylation is sufficient, then fermentation or substrate level phosphorylation wouldn't be. So we're kind of switching but this gets a lot into like the philosophy of why we would propose the therapies that we do. This has not so much to do with cancer metabolism in general. I think most of the field agrees with us that cancer metabolism is a very important target. But if you get into the weeds and you say, well, if mitochondrial function is completely normal, what would prevent a cancer cell from, you reduce glycolysis, you reduce glutaminolysis, glutamine utilization, and you switch to fatty acids or ketone bodies, your normal cells would switch, but you would expect your cancer cells also easily transition to this different bioenergetic mode, and that doesn't seem to happen. Cancer cells seem to be much more dependent on substrate level phosphorylation flux, that is glycolysis, glutaminolysis, whereas normal cells are much more flexible, more versatile. And I think this makes sense also considering evolutionary biology. Cancer cells acquire genetic defects, mitochondrial defects in signaling. It's hard for me, from just a basic kind of physics consideration how would that be an advantage or like an adaptation to the cancer cell, a loss of function. So yeah, I think that would be the overview of
So,
that.
okay, thank you. Two follow-up questions like come to mind based upon a lot of questions that I get.
It's likely that if you're listening to this podcast, you probably take supplements on most days. And if you're going to take something day in, day out, I bet it's pretty important to you, like it is to me, to know that it doesn't contain a bunch of harmful, crappy ingredients, right? I know that I really, truly care about what I put in my body, especially because I'm breastfeeding. I have a little guy that's running around all over the place. And that's why I love Puree. They make incredible supplements with high quality ingredients, so I never have to second guess what I'm taking. I especially love their Puree O3 supplement, which is their fish oil. So this is third party tested for more than 200 plus harmful contaminants like heavy metals, pesticides, PCBs, dioxins, and much more, believe it or not. And what's more, every single bottle comes with a QR code. So you can see all of their third-party lab testing data on every batch on their website, which is going to be covering everything from label accuracy and purity data points to freshness measured in Totox. That's total oxidation. I've personally been taking their omegas to help with a variety of things, to hopefully help reduce inflammation, to support brain function, and the fact that I'm breastfeeding. So to support and nourish my little one as I'm feeding him too. And I love that I'm getting a potent dose of EPA and DHA. Head on over to Puree, get Puree O3, add it to your routine right now. And I have a fantastic deal for you. Right now, you can get an amazing 20% off. And if you choose their already discounted subscription, you get almost a third off the price. This is available when you visit our exclusive URL. That's puree.com/metabolic link and use the code metabolic link. That's PUORI.com/metabolic link. Use the code metabolic link and you'll be able to save 20% off when you make a one-time purchase, which is an amazing savings. So head on over and I hope you enjoy them as much as I do. Now back to our episode.
So you're saying that if someone has a driver mutation, maybe BRCA, KRAS or something, there's people walking around with driver mutations that are maybe have great metabolic health that are suppressing, the spontaneous oncogenesis of
Yeah.
that. So, with a BRCA mutation, BRCA1, I think it's maybe a 50% chance that you would get. So you're saying that even in the presence of a persistent molecular pathology, for example, a driver mutation, that metabolic health and maybe as a preventative measure, periodically going into therapeutic ketosis or things like that can conceivably suppress the genes associated with that. And what is the percentage of people that may have, you mentioned KRAS and some of these driver mutations that would make them uniquely susceptible to cancer? I remember this literature 10 years ago, like really delving into it, trying to figure out Dr. Seyfried's theory a little bit
Yeah.
more, but has our thoughts changed on that?
Uh, not really. I think one of our colleagues is doing also a deep dive on like the germline syndromes, Lynch syndrome, Li-Fraumeni
Mhm.
syndrome, the familial adenomatosis,
Mhm.
and most of these. Well, I think in terms of prevention, as you say, conceivably it makes sense. Uh, I think it would be hard to quantify or to, you would have to have like a very good diagnostic screening schedule for some of these syndromes that have so high penetrance that you would, how healthy can you get your normal metabolism to prevent the risk factor? So that's always the kind of the question or the argument that we get against, like, oh, well, these mutations must be primary causes. And yes, in the sense that, if we don't have the technology or the knowledge to prevent the malignant transformation in these cases, then yes, but none of them are 100% penetrant. And if you look, I did a deep dive, for example, in neurofibromatosis, and they get a lot of benign, fibromas, but to get like MSP and the plexiform fibroma or like the malignant fibromas, that is not as common. So there has to be like a cascade of events that has to happen for a normal cell to become a malignant cell. And as I said, we believe this is mediated by by mitochondrial function. So if conceivably, if you could keep your mitochondrial function healthy, then this switch wouldn't happen. Now,
Yeah.
if lifestyle is enough, or if you would need to throw in like a bunch of supplements or some even drugs to, coenzyme Q or something to try to restore function, I don't think we know that for sure.
Mhm. Well, without mentioning any names, there was a very top tier NIH, NCI investigator that gave a talk at USF years back, and they made the statement that cancer cells have perfectly normal mitochondria. And they did reference some articles on that. And I remember I was in the audience. I asked a question and respected the person. They've done a tremendous amount of work, like in the field. So if people have some pushback, on the idea that cancer cells have defective mitochondria, meaning that if we look at them, they're not respiring, or that I guess by definition that there's a metabolic coupling where ATP is just O2 consumption is coupled to ATP. So has that been shown? And when you say mitochondrial deficiency, you could talk about impaired mitochondrial function or the number of mitochondria.
The number, the
Is yeah,
structure, the
yeah.
dynamics. Yeah, so this is the very common argument. I mean, I during my PhD, I work a lot with seahorse and doing
Mhm.
respirometry. I mean, it's very hard to argue that there is no oxygen consumption in cancer cells. So they indeed do consume oxygen. Now, how much of that is coupled? You do the oligomycin inhibition of complex 5 and try to like figure out, okay, there's a little reduction in OCR, in oxygen consumption rates, and try to say, well, maybe this was the ATP, but that doesn't tell you. So maybe I could take it a step back. That doesn't tell you much about like ATP sufficiency or SLP, substrate level phosphorylation dependency, or oxphos sufficiency or oxphos insufficiency, which is kind of the more conceptual, whether the amount of energy that is being produced by the efficiency of mitochondrial metabolism. And the problem with mitochondrial metabolism is that it's not like one step. It's many steps that through many different metabolites that feed into the TCA cycle and create the electrochemical gradient. So you have, as you said, you have number of mitochondria, you have structure of mitochondria, you have the dynamics, mitophagy. All these things could impact how much ATP in general across the chondrion, the mitochondrial population within a given cell, how much that ATP, if it's sufficient for the cell to stay alive, or if it has to gradually start upregulating substrate level phosphorylation, so fermentation, to stay alive, and which, in my mind, going to evolutionary biology, if you go 4 billion years ago with Luca, and then 1.5 billion years ago when the endosymbiotic event of a prokaryotic precursor with the mitochondria that entered by endosymbiosis. If we look at it like that, and that is when multicellular organisms start to arise, and that is when cancer start to arise. So if mitochondria is insufficient, let's call it, or inefficient in their function, this could create this regression to like the ancient phenotype of prokaryotic organisms, of like bacteria, which is to proliferate without control as long as nutrients are available. So
Mhm.
so mitochondrial function is there, of course, and you need some of the functions of the electron transport chain, in quotations, because sometimes row zero cells can still, you can still keep them alive, but you need to supplement them with a couple of things, uridine and pyruvate. So electron transport chain might be necessary for optimal proliferation, but for sure for viability, I think you don't need oxidative respiration at all. You can go by with glycolysis and glutaminolysis that creates enough energy. So the problem in biology is everything is sort of a gradient, as you know, as always. There's not many binary systems. So if you say mitochondria is defective, I think most people imagine, okay, so must be that you have like 3 mitochondria that are barely working, they have no cristae, and you cannot see any function. That's not the case. It's just
Mhm.
the reduction of function is sufficient to make the switch to substrate level phosphorylation dependency, and for the cell to start behaving as a cancer cell. And yes, then it accumulates by ROS metabolism, by oxidative stress, they accumulate mutations in different genes. I always found it curious that it's kind of the same genes. I mean, the mutations are random and they kind of spread out through the genome, but the required mutations are always similar. Of course, you could argue that's backward selection. Only those clones that express those characteristics get selected. But I don't think that's driving the adaptation to the loss of oxidative phosphorylation function, the genes.
Yeah.
But I don't think that's the primary driver initiating the whole system.
Okay. Yeah. So for our listeners there, it's like sort of the idea, the oncogenic paradox, right, is where you have multiple provocative agents cause progressive mitochondrial dysfunction, and then essentially the retrograde response, or maybe there's different names for it, is signaling an energy crisis. And then you have a gradual transition from OXPHOS to substrate level phosphorylation. And I think the prototypical cancer representative of that is glioblastoma, because glioblastoma, especially with the anoxic core, and the massive amount of fermentation, hypoxia, you have the level of hypoxia is such that like mitochondrial function would be hard to happen at the core. So let's transition a little bit. And this is very fundamental for convincing people, like oncologists, of this.
Absolutely. I think
This
it's
is
also
part of the
like,
discussion, when it's trying to get them on board. Yeah, I've been there
I
many
think it will
times.
justify why we do the things we do.
Mhm.
But it's not the only explanation. I always try to keep an open mind. You can have ketogenic metabolic therapy without even, getting into bioenergetics, really.
Yeah.
You can say it's due to the signaling effects or the inflammation or the insulin signaling, all these things, the growth signaling, mTOR. You can explain it through different ways that do not require um, targeting of substrate phosphorylation, glycolysis, glutaminolysis. But I believe that this will be the key uh, thing to elucidate and to delve deep into more in terms of clinical applications, because right now metabolism is kind of like a afterthought. It's like a secondary consideration that when you even the people working in the field trying to target metabolism, they always have to is sort of unpopular, I guess. So they always have to like tag it with something else. Immunometabolism. Let's make
Yeah.
checkpoint inhibitors work better, or let's make some other drug work better, or chemotherapy work better, which is fine. It's all right as a first step. But I believe that the first approach, the core approach, should be targeting metabolism in general, but the only way in my mind to do it is ketogenic metabolic therapy, dietary and pharmacological, and then build onto that the other therapies, which are still useful. Chemotherapy kills cancer cells, but maybe they could be adapted a little bit, and you could use lower dosages. But of course, I understand within the standardization of the procedure, oncologists are very afraid to, even legally, you cannot lower the dose just because you feel that doing these other therapies will have the same effect, and until you have the clinical data to support that. So
Yeah.
so that is kind of where the barrier is right now.
I am so excited to share with you an incredible scientific breakthrough to support long-term health and wellness. C15 is the first essential fatty acid to be discovered in 90 years, and it's really incredible. And it works in multiple ways. It repairs age-related damage to cells, protects them from future breakdown, boosts mitochondrial energy output, and activates pathways in the body that help regulate sleep, mood, and natural repair mechanisms that support overall health. This functionality leads to a slew of exciting benefits now and as we get older, namely improved metabolic, liver, and heart health, smoother functioning joints, deeper sleep, and healthier skin, hair, and nails. Now that's essential, right? And did you know that many of us are actually deficient in C15, which results in weaker cells that make less energy and quit working earlier than they should? All of this makes us age faster, sleep poorly, feel sluggish. Does this sound familiar at all? Fatty 15 is on a mission to help you replenish your C15 levels and restore your long-term health. And you can get an additional 15% off their 90-day subscription starter kit by going to fatty15.com/metabolic link and using the code metabolic link at checkout. That's fatty15.com/metabolic link. Use the code metabolic link at checkout for 15% off. Now back to our episode.
And we're talking about the Warburg effect, and that's a controversial topic and effect even among oncologists. So the
Yeah,
oncologists
correct.
do not target the Warburg effect, but they embrace the Warburg effect because the underlying imaging technology used, that's a gold standard for imaging the location and aggressiveness of tumor, is a fluorodeoxyglucose PET scan, FDG PET scan. So they use that technology to image the tumor. It's more or less the gold standard, but they don't use that information as of now. If you were to just, do a search with AI, do
Yeah.
oncologists target the Warburg effect or metabolism? And it's no, it's not part of standard of care at all.
Yeah, I would even, if I can, I would even the Warburg effect. I don't like the term to be honest, because it doesn't really say what we want it to say, in the sense that the Warburg effect is basically just pyruvate to lactate, really, and that doesn't make any ATP. That is just for the redox balance to replenish NAD plus. So I prefer substrate level phosphorylation, which is the ATP generated substrate level phosphorylation flux, which is the 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 pathway through Embden-Meyerhoff-Parnas pathway of glycolysis, where phosphoglycerate kinase and pyruvate kinase generates net positive ATP, which if we are going to target bioenergetics, we do have to focus on that. Because FDG PET scans, they only really consider the glucose uptake. So I'm sure somebody would argue that that doesn't really tell you what the glucose is used for, whether it's used for it goes to fermentation through the Warburg effect, or if it's used inside the mitochondria. There is a limit to how much glucose and pyruvate derived from glucose mitochondria can use. So whether it's because it's like a signaling, the proliferation is so fast that it exceeds the limit of what you can oxidize, and then it spills over to lactate, or it's because the mitochondria itself cannot process this because the oxidative phosphorylation is inefficient, and that's the primary cause for this effect. We don't know, but yes, the Warburg effect, glycolysis is upregulated in most cancer cells. I don't think anybody would argue with that, but for some reason it's has not been considered a feasible, I guess, target. I mean, there has been clinical trials trying to target glycolysis, but we know from the data that is not sufficient. You for sure have to target glycolysis and glutaminolysis as the two main fermentation pathways or substrate level phosphorylation pathways. You have to target these together. So if you just target one and not the other, you don't get sufficient therapeutic effect.
Is there an imaging technology for radio-labeled glutamine where we could do an FDG, glutamine scan in
Yes.
tandem? Yeah.
Yes. That's one of my also pet peeves. It's step number 3 in the paper
Mhm.
that I go through all the metabolic certifications. I did another review on this. So there's many PET tracers that would be very interesting to do. You could look at apoptosis. You can look at oxygen consumption. You can look at different amino acids, fatty acids, metabolomics. So there's many ways I think we could, if the primary objective was to target metabolism, we could use many of these interesting tools that are, mostly for research right now. There is some, first in human pilot studies to use these PET tracers or magnetic resonance spectroscopy to look at these metabolites, but it's not standardized. So all you can do, really, all you can do in terms of looking at bioenergetics if you get diagnosed with cancer is looking at 18-fluorodeoxyglucose PET scan. But at least that would give you like a primary, like a preliminary idea of, okay, my tumor, for sure, if there's very high glucose uptake, then targeting glycolysis would be a good first approach.
Yeah.
And it's very unlikely, I have yet to see a cancer cell that wouldn't display this substrate level phosphorylation dependency. So this increased dependency on glycolysis and glutaminolysis as a baseline. After you cover that, after you have a cancer cell that has sufficient glucose, let's say, and sufficient glutamine, then to grow efficiently, yes, you need other amino acids. Yes, you may be able to use a little bit of lactate or a little bit of fatty acids to support whatever oxidative phosphorylation you still have. But that's a different question. Is it like after you've covered what you need, if you can use a little bit of other things, that's different from if the primary intention is to target metabolism and strip away and inhibit what the cancer really needs to kill the cancer cells, then whether lactate can or cannot be used as long as you have enough glucose and glutamine, that's not really very important for
You
the
just
therapeutic application.
Okay, you just made a statement, sort of like a blanket statement that you had not seen a can like all cancer cells kind of have that. And I want to pivot a little bit to really talk about your review, the clinical framework for ketone metabolic therapy and glioblastoma. But before we kind of jump more into brain tumors, and that's kind of like the prototypical target for this because standard of care doesn't work and it has a very, very prominent, metabolic phenotype. But I wanted to ask the question because I get many emails and people ask, so other cancers, for example, leukemia, lymphoma, testicular cancer, maybe even prostate cancer in there because it's a little bit more indolent, right? It does not. What we're talking about today, is it your opinion that ketone metabolic therapy or targeting energy metabolism would apply to AML, CML, multiple myeloma, those cancers too. So I'm sure there's a lot of listeners out there who have or may know people with these
Yeah,
types of cancers.
we get this question a lot. I do believe yes, in the sense that when I say I haven't seen or found, and I'm also looking for it in the lab, a cancer cell that would be that would have normal oxidative phosphorylation in the sense that it would not require these fuels. I have not, and even if you search, just try to find in PubMed any cancer study in vitro. Of course, in vivo it's not possible to do because there is all these metabolites are always there, so you have to use drugs to inhibit them. But any in vitro system where you would have cancer cells growing in the absence of glucose and glutamine, I have not found this study. You can have either or, so you can have cancer cells barely living in glutamine alone with dilycidum and some other things,
Mhm.
or unable to proliferate in glucose alone because you need the nitrogen from the glutamine and the biosynthesis. So you can have those. So for a cancer cell to stay alive, yes, it needs glycolysis and glutaminolysis. And there is some other metabolites can feed into those pathways that could compensate a little bit. In the absence of glucose, you could use a little bit of uridine, but that doesn't apply in vivo because the uridine is not, they say it's, like 15 micromolar in the microenvironment, but
Mhm.
that is not enough to support tumor growth. So really, you need glucose and glutamine to cover the ATP sufficiency, which is just to cover the sodium potassium pumps, the
Yep.
basic energetic requirements of the cell.
Yep.
And on top of that, yes, it might be possible that a prostate cancer or some other cancer might have a little bit of preference to, if you have enough glycolysis and glutaminolysis, to incorporate lipids into the TCA cycle or a little bit of lactate to be incorporated also as carbons to the TCA cycle.
Yep.
But that's unrelated to the treatment. The treatment is we're going to target glycolysis and glutaminolysis while we switch to ketone body metabolism. And
Yeah.
if those two are absolutely essential and required for proliferation, you will get for sure a reduction in proliferation rates. Whether it will
Mhm.
kill the cell, whether a tumor cell that is inhibited enough to be forced to use oxidative phosphorylation without substrate level phosphorylation, and it just hangs there and it uses all the other fuels to just stay alive, but it cannot grow. I don't. That doesn't really fit the definition of cancer because
Mhm.
a cancer cell that does not grow is not a cancer cell. Um, but then you have to figure out how do you sustain this? How do you use these different drugs to keep the pressure, the metabolic pressure on, so there would not be a recurrence. And nobody knows. We don't know if after a while of targeting metabolism, maybe these cells, whatever is residual, uh, maybe they normalize their phenotype and they just stay
Mhm.
without proliferation.
That's an interesting question. Yeah, I think there's so many, unanswered questions about, the fundamental bioenergetic properties. But I do want to get into sort of the therapeutic application and the implementation. But I would be remiss if I didn't ask the question, because it comes up in even the title of many top tier, high impact peer reviewed publications is cancer cells thrive off fat, off ketones, and under certain contexts. So I get this question a lot. And if the two fermentable fuels, right? You talked about the sodium potassium ATP pump,
Yeah,
right? And I think in neurons, it's something like 70%, because I'm teaching neuroscience now
yeah,
to the med students. It's like 70% of the energy,
yeah.
and in cancer cells, I think it's, it depends on the cancer, but like at least 50% of that ATP needs to drive that pump to maintain that membrane potential.
Yeah.
But there's also a lot of proliferation and a lot of biosynthesis.
Yeah.
And I do
The
know that, fatty acids and glutamine, I think actually glutamine, maybe 50% or more of glutamine is de novo lipogenesis in the tumor. So maybe a little, if you could summarize the potential role of fatty acids and ketones for the growth of tumor, maybe bioenergetic wise, but also from a biosynthetic perspective too.
Um, yeah, I mean, this is always the argument that we get into. I have no problem with considering that any metabolite really fulfills a function. I mean, it would be strange if if a cancer, unless the transporters or the enzymatic machinery is not present to even process, which might be possible because if you are proliferating using substrate phosphorylation, perhaps you don't upregulate some of these transporters for lactate or for ketone bodies. But if it's in the environment, I do suppose that some of it is used, but and it will support lipid synthesis and anaplerosis for sure. Uh, the 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 core of the argument where we get is you can only support oxidative phosphorylation with ketone body metabolism or fatty acids to the level of OXPHOS efficiency that you have in the cell. If the original argument is that OXPHOS is insufficient, there is OXPHOS insufficiency, which leads to substrate level phosphorylation dependency. Even if you oxidize 100% efficient, whatever the cancer cell has, if it oxidizes only ketone bodies, 100% of OXPHOS, it's still insufficient without substrate level phosphorylation. So I would still consider the first thing we need to do is to target substrate level phosphorylation flags, glycolysis, glutaminolysis. And then, yes, if we do some labeling studies or some metabolic studies to see, oh, I see the cancer cell is still living. Let's look at different metabolites that might be using to stay alive. But I can pretty much guarantee, at least from the literature that I've seen on my own experiments, there will be a lack of proliferation. If you don't have glucose and glutamine, cancer cells cannot divide. So I think that would be the first thing we should do in the clinic too. And then we can go back and maybe some cancer cell is barely hanging on using lactate oxidation or ketone body metabolism. And there's different drugs that you could use. Of course, they would have also toxicity to normal cells because at that point you would have to be your normal cells would have to be very dependent on ketone body metabolism. So inhibiting it would be problematic, but it could be done too.
Mhm. Okay. I'd like to add that with Professor Seyfried in 2014, we published in the International Journal of Cancer when we added ketones to the VMM3 at 25 millimolar glucose, like high glucose, it actually decreased the proliferation, and we saw we're adding ketones, I think
Yeah,
at 2 millimolar. So that was kind of an interesting observation to
yeah, I've
us
seen
that
that
the
too.
ketones by themselves had this anti-proliferative effect. And also we counted more dead cells using a live dead cell analysis of the
No,
GB.
absolutely, absolutely. We see that too. I mean, maybe you said 25 millimolar. That might be.
That's what you grow the VMM3. It was always weird, because
Oh,
we got
the
these cells.
glucose or
Yeah,
the
the
ketones.
glucose. Oh, yeah,
Oh,
yeah.
yeah, yeah.
Sorry.
No, yeah. The
Yeah, yeah.
complete
The
media, yeah,
glucose was that.
it's
And then
it's
the
very high.
ketones. I might have misspoke. And then the ketones were like a level that you could achieve, with the diet. It was like 2 millimolar, I believe.
Yeah, yeah, yeah,
But
yeah.
I
I
did. we actually replicated that because to convince ourselves that this was happening, at least in that GBM model, that's what
No,
we
no, absolutely. We see that too when you add the ketones to glucose and glutamine, those the baseline conditions, it can inhibit proliferation too. It would be hard to know whether it's because of redox balance or whether it's because it's an overload of the system of the TCA cycle or too much ROS
Mhm.
through the oxidation of the ketones. But yeah, that's
Or
also.
hexakinase. There's somebody that studies hexakinase and was like, yeah, no, that's what it's doing. It's inhibiting hexakinase. But I think there was like one paper and that was loosely said something like that. So the idea then for the implementation is to target for ketone metabolic therapy to target glucose and glutamine. And in the context of ketone metabolic therapy, let's switch a little bit more to glioblastoma, right? Because that's really, I think, the target cancer that it's almost a really important proof of concept to move, and that's where the field has moved the most. And for various reasons, I got interested because the ketone metabolic therapy can control seizures too, and so that's a is that something to maybe consider? I guess right off the bat, who should not consider ketone metabolic therapy, for example, if they have a BMI under 19 or 20 or something like that? Is this a no-go for them?
Uh, Not really. So maybe we could step back. So when we say ketogenic metabolic therapy, I usually consider that as kind of so dietary ketogenic metabolic therapy, which is ketogenic diet or fasting or a little bit of calorie restriction. That is kind of the requirement or the sine qua non to the essential step for you to be able to later target glycolysis and glutaminolysis,
Yeah.
SLP metabolism. So maybe this often gets confused because yes, it has therapeutic effects on its own because it's basically putting the organism, the physiology in a state of less growth, of less available resources, less inflammation, less growth signaling, less insulin signaling. So it's kind of like an inhospitable environment for the tumor to grow with this dietary switch. Um, and it might have, and it for sure has, inhibition of growth rates. But it might not be sufficient unless we would posit somebody doing like a 60-day fast or something a little bit more extreme. It might not be sufficient to like get rid of the tumor. And I think this sometimes we get these comments in our videos or in our papers. People are so interested in the diet because it's something they can do and they want to implement this. And I think it's good. I think I'm very convinced that uh, ketogenic metabolic therapy, both dietary and pharmacological, on top of standard of care is better than standard of care alone, even
Mhm.
even without like super definitive clinical trials. Uh, so it's better than doing nothing. But as I say, it's a way to create an inhospitable environment that the tumor is more vulnerable to other therapies after. These other therapies could be chemotherapy, could be radiation therapy, could be immunotherapy from the standard of care kit, or could be repurposed drugs, or could be metabolic inhibitors, which is really what we feel it has been lacking. It's very underdeveloped to consider targeting cancer metabolism first as a way to weaken the cancer cells as much as possible, and you have to do it strategically. You can also target glycolysis and glutaminolysis without any previous adaptation to ketone body metabolism or to fat-derived fuels and to upregulate oxidative phosphorylation in your normal cells. But the risk of toxicity is higher. So you do need to, unfortunately, I say because it's very confusing for physicians and even for the patient. Diets are very like esoteric. People don't understand. What you need to achieve is like a biological effect in your physiology in your body that will make it more difficult for the tumor to grow. It will make your normal cells more resilient. And after you have that baseline, which in my mind, you can only achieve at least at this point with the dietary strategies, because it's like a whole body systemic change. I know you are a big fan of exogenous ketone bodies, so maybe those can also help, but I'm not sure if they would signal fasting sort of, I guess, to the organism, but I'm not sure if they would also reduce glycolysis or insulin signaling if you're still eating, 300 grams of carbohydrates a day, even if you
Oh, yeah,
supplement
not in that context. Yeah, I see them as a nudge, for a tool to put the GKI where we know that if we get it under 2 and maintain it.
Do you find yourself dragging around that 3 p.m. mark, but you also feel like you can't get in enough coffee to feel better? That used to be me. And believe it or not, after having a baby and really not sleeping much over the last year, I now have more energy without coffee than I did with it. I know it sounds insane, but it's true. Caffeine dependency is no joke. And if you're struggling to get through the day, it might be time to switch it up and give mud water a try. Packed with cacao, chai, lion's mane, chaga, reishi, cordyceps, turmeric, and cinnamon, mud water gives you a smooth energy boost without heart racing jitters. Think of it like coffee's chill, yoga loving cousin who just went on this really amazing retreat and's come back really calm and zen. That's mud water, helping you sleep better at night. It's more than just a coffee alternative. It's loaded with adaptogens, antioxidants, all those health packed ingredients that I mentioned. Truly makes you feel like the healthiest person in the room. And every single ingredient is 100% USDA certified organic, non GMO, gluten free, vegan, and kosher. There's also zero sugar and no sweeteners added. You simply drop your mud water powder into your favorite mug, pour some water on it, and give it a mix. There's also, which I love, caffeine-free blends, which are my personal favorite as I've been caffeine-free for about 2 years now. If you're ready to make the switch to cleaner energy, head on over to mudwater.com and grab your starter kit today. Right now, our listeners get an exclusive deal up to 43% off your entire order, plus free shipping and a free rechargeable frother when you use the code Metabolic Link. That's right, that's 43% off your entire order, a free shipping, rechargeable frother with the code Metabolic Link at mudwtr.com. After you purchase, they'll ask how you found them. Please show your support of the Metabolic Link and let them know we sent you. Keep your energy natural and feel refreshed all year long. And do it with mud water because life's too short for anything less than clean, delicious energy. Now back to our episode with Dr. Tomás Duraj.
So yeah, I think I'd like to talk about the glucose ketone index and achieving a GKI of 2 and under to set the stage for other therapeutic, to enhance the efficacy of other therapeutic modalities. And that could be metabolic based drugs that target glucose and glutamine. Maybe you could think of ketone as a drug to enhance that. But also, chemotherapy, radiation, and immune-based therapies, in particular, the checkpoint inhibitors, which I know Dr. Seyfried maybe has some mixed feelings about that, but there is a body of literature showing that ketogenic therapies, even 2 weeks of a ketogenic therapy, can greatly augment the adaptive immune system in a way that would enhance the anti-tumor effect, and that could augment the effects of these checkpoint inhibitors. So that's actually a big interest in the Moffitt Cancer Center, our collaborators. So that's almost their primary interest, is
Yeah,
making the standard of care work better.
yeah. I would say the Dr. Seyfried, not to speak for him, but I think the frustration he has with like immune-based therapies is he would say that they're based on the wrong underlying theory.
Yeah.
Now the immune system, I think it's sort of independent of any grand theory of cancer origin. However, if you say you want to sensitize um, the immune system to recognize these epitopes, which are neoantigens caused by the somatic mutations, if from the get-go you consider that these mutations might not be, first of all, they might not be the origin of the disease, but also they might be random. And I've seen considerations to even like increase hypermutations, like you see with temozolomide, for example, to create even more mutations to to allow the immune system to recognize.
These are
We'll see.
DNA damaging agents,
Correct.
whereas maybe the immune-based therapies would not be. That's like augmenting T cell, activation
Yeah,
and
the
coaching,
normal
but then
function.
that could attack your own healthy tissue too. So I
Yeah,
think,
yeah, but I mean, it is true that those mutations are there, even if it's like a downstream consequence of the mitochondrial dysfunction or the mitochondrial, uh, you know, uh, reprogramming, if you will. So if they are there, they can be recognized, and if you can potentiate your immune system to be better at doing its job, and you get rid of the acidification in the microenvironment, and they can kill the cancer cells. I think that's of course desirable.
oh, well, one thing that came up in a discussion over the weekend with colleagues is that oncologists typically like to use with standard of care like the maximum tolerable dose of chemotherapeutic agents, and there's this idea that you use the minimum effective dose. So instead of use like 20% of what you would typically use in the context of ketone metabolic therapy, you could potentially have no side effects and a greatly augmented response, right? And I think Dr. Elsaka maybe did that, or maybe there's some
Yeah, yeah.
trials, some proof of concept
In
trials.
chemothermia and Dr. Slocum and this
Welcome, yeah.
metabolically supported
Hmm.
chemotherapy that they do in a center in Turkey. I find that very interesting. Um, Now, as I said, the clinical aspects of doing that at a population level, at a large scale, might be a little bit difficult. So I never want our approaches to be like conflictive. I think sometimes we are a little bit unnecessarily conflictive, in the
Yeah.
sense that this, in my mind, this is also like an invitation to others in the field. And you see me, I'm a younger researcher that just coming in the field, very excited to try something new. And I think there's many others like me that are just, maybe starting their PhD or just starting a postdoc position somewhere that want to do something different. They don't want to do
Mhm.
always the same sort of. Okay, I have a cancer cell, then I do like this massive genetic screening. I see hundreds of
Yeah.
different targets. I'm not so convinced that will lead to anything. Most of as you know, most of the things that are published, nobody even reads. It's so much data. Like good papers in high impact factors journals have so much data that nobody can process it. So it stays there just in case somebody will find it of interest, like 20 years later. So maybe going a step back and trying to figure out the basic requirements of what keeps cancer cells alive in terms of bioenergetics, and then building clinical therapies for my clinical colleagues that want to maybe do a clinical trial, small thing, pilot study, trying to
Mhm.
target metabolism. But as I said, it needs to be done in this context of adapting the body first. Because yes, there is clinical trials for glutamine inhibitors, for
Mhm.
DRP-104, this DON
Mhm.
prodrugs or CB839. Many of these drugs are in clinical trials, but they are always applied in monotherapy on top of
Yeah.
standard of care, basically. And they might still have some benefit, but I think it will be less impressive than you would see if you did like a combinatory trial. Now, if you do a combinatory
Mhm.
trial with like, there's a couple of them, there's CASP9 and Combat MEMAT, there's different trials that did, 5 drugs, 9 drugs, then it's very difficult to figure out what worked. But I think the
Mhm.
patient is more interested in having a good outcome first, and then maybe going back and figure out what really did it. So this also, I think, the way clinical trials or clinical studies, interventional experimental studies are done in the clinic, I think it needs to be adapted a little bit for this new era. And I think most people agree with that. I just listened to different podcasts. Like most oncologists, top in top medical schools, they agree with this. Like, yes, we need to have different drugs at the same time, like
Yeah.
multi-interventional trials. But we just cannot do them because the way the industry is set up doesn't allow or doesn't favor. Not it doesn't allow it. It doesn't favor these sort of like platform trial with 5 drugs at the same time on top of a
Mhm.
diet, which is even more
Yeah.
more complicated. So, but I do feel really that that's where the field
Mhm.
needs to go.
Yeah, and the mutational heterogeneity in a GBM is just like crazy, right? There's so many
Exactly.
mutations, even in the same, even in the same tumor. It's not like CML where like Gleevec is targeting like a
Just
particular, it's
one
much different
one pathway.
than that. So let's talk about, so the biggest lever where the rubber meets the road really is changing profoundly a person's metabolic physiology to change the tumor growth, proliferation, and the tumor microenvironment, which influences invasiveness and metastasis, right? So I think you would agree that the GKI, which is talked about a lot, it's like kind of the central piece of the ketone metabolic therapy. Inducing and sustaining a GKI of 2 and below is like the biggest lever we could pull. So would you agree with that statement?
Uh, yes, with some caveats, and we see this in the emails we get, and one of the things you also mentioned is this sort of might frighten people, or
Mhm.
people get a little anxious of what does this mean, because this is like an arbitrary number based on some preclinical work, but I would say what what you want to do is to mimic the metabolism of fasting as much as possible in your physiology without fasting, because you cannot fast forever. So the most efficient way to have a good GKI, of course, kind of if you want to know your baselines, if you want to know how low will your glucose go and how high your ketones will go, you can do like a 5 to 7 day fast. Of course, with the necessary precautions and preparation and electrolytes and refeeding schedule. And you just measure it at day 5, 6, 7, and you will get like the numbers that in your own body, in your own physiology, would be adequate to the status, the health status that you might have at that moment. But yeah, you cannot fast forever. That like this 100% caloric restriction, which eventually will lead to malnutrition. So that's why the ketogenic diet was really developed, as you know, for epilepsy.
Yeah.
Um, but the intention in cancer is a little bit different. Is you are trying to ride the wave to get as close as this fasting condition as possible, while still having enough nutrition, enough protein, good quality protein sufficiency for your lean body mass, uh, while putting pressure on the tumor cell. So I would say the absolute glucose levels are also important. I am not super convinced that if you have a patient that has a glucose of 140 milligrams per deciliter, 6, 7 millimolar, and has even high ketones at the same time, I'm not sure that would put pressure on the tumor cells. That would be the situation that I mentioned before, is that glycolysis would be most likely sufficient. So if ketone
But
bodies
the
are
GKI would be high in that condition, right? So
uh, well,
I'm
if you
more
have
with 140, yeah, or
if you have
anything.
if you I guess if you supplement, or if you of course if you have diabetic ketoacidosis, but if your glucose is 6 millimolar, I think feasibly
Mhm.
you could have 6 millimolar of ketones with a GKI of 1,
Yeah,
without really putting pressure on the tumor. So, and the reasons for this might be different. You might be exercising, which is different. That
yeah.
would still put pressure on the tumor cell. You might be stressed, you lack of sleep, or some dietary non-compliance that would raise your blood glucose while ketones are still elevated. So with the GKI of 2 or below, basically this is more, think of it more as a chronic uh, number, or as something sustained that you aim for, with the understanding that there will be variations across the measurements. One of my big frustrations in the clinical trials is that most clinical trials did not do a very good job with measuring glucose and
No.
ketones, despite being like the primary uh, kind of outcome that you would want to achieve. So I think that will change with continuous glucose monitors, continuous ketone monitors that are coming on the market.
Yeah.
Uh, so you would aim for your glucose to be basically as low as possible within physiological range. Also, people get a little, extreme with
Yeah.
this, and they trying to, push it with metformin or SGLT2 inhibitors. I think they are useful tools to get it as low as possible. Uh, but your glucose probably shouldn't be like 1 millimolar. That's probably
Yeah.
not good. But looking at different fasting studies, long-term fasting, very long-term fasting. Angus Barbieri, the man that fasted for a year, and other studies that look at like 60 days or 6 months of fasting, because fasting used to be very effective treatment for obesity in the 60s and 70s. So in those studies, you can look at glucose, and you see that it can hover around like 30 to 40, even 50 milligrams per deciliter sustained for months on a time. So I think that would be like the most extreme level limit of glucose availability in the blood that evolution for some reason selected. If you fast for a year, you would expect glucose should be zero, but no, there is always some gluconeogenesis. So that would be you would try to have your glucose as low as possible, and your ketones, as you know, they adapt to the situation. So if you have more activity, or you put more fuel in the body, or MCT oils or something like that, your ketones can fluctuate throughout the day. So you cannot really control the ketones that much, but you can try to have your glucose as low as physiologically possible in a sustained manner, with the ketones trailing behind, and that is the GKI in my mind. So it's not only the glucose ketone index number that people get so obsessed about. It's the number over weeks and months and years.
Average.
The
Yeah.
average that you would be aiming at. With ideally you would measure a molecular, you would do a tissue biopsy, and you would measure your mTOR and your MPK signaling, and your insulin signaling, IGF-1, and all these things. If you could sample that, that would be probably more informative than just the GKI. But the GKI is like a proxy approximation that you can derive in most circumstances. A low GKI chronically indicates that the body is putting pressure on the tumor and putting metabolic stress on the tumor, with some exceptions, of course. So there are circumstances where it doesn't track.
So we're talking about, ketone metabolic therapy is in the context of a glioblastoma or cancer therapy, it uh, should be guided by an experienced, ideally a dietitian, registered dietitian, or a clinical team that knows how to do it. And I think, the lowering of the glucose can be the most stressful and nerve-wracking for most. And we do have tools. So maybe the first approach then could be a dietary approach using things like MCT. And then if the glucose is hovering around 5, then you have in your toolbox metformin, SGLT2 inhibitors. And I've found personally and with other patients is that titrating in even relatively small amounts, maybe 10 grams 2 or 3 times a day of beta hydroxybutyrate salts that have a glucose lowering effect. And conversely, it's going to raise your ketones, so it's going to lower your GKI. So we do have a toolbox of tools, that can do that. But I think the most important thing is to really have that clinical guidance of a well-formulated ketogenic diet that is sufficient in protein to prevent cancer cachexia, and to maintain that, especially unless, if the patient is obese and has a high BMI, then you have the liberty of doing a restricted ketogenic diet. But I do know Thomas Seyfried is very adamant about the restricted caloric restriction, and that definitely enhances. But often you get situations where the patient is underweight, and that becomes, I think, that becomes where you want to maybe use the exogenous ketones or drugs off the bat to achieve and maintain that GKI.
Yeah. I think I did answer your question before, like who should not use ketogenic metabolic therapy or dietary ketogenic metabolic therapy. So yeah, if you want to bring restriction to somebody that has a BMI of 18 or below, I would argue that person is already probably caloric restricted. So there you would aim to do the metabolic shift, so the shift in fuel partitioning or fuel utilization, using dietary ketogenic metabolic therapy, so a well-formulated ketogenic diet. But you would try to avoid caloric restriction and weight loss. And I know this can be tricky, and for those cases, I think it does require a trained dietitian that could help. Unfortunately, most dietitians are also not really trained. They are trained in supporting different diets, but not always specializing in ketogenic diets, which also is something that we will need more training and more professionals working. But if you can achieve this state with different dietary approaches that can be a little bit more flexible depending on the initial circumstances. We also find, Paleolithic ketogenic diets, which is sort of like an euphemism for a carnivore diet. Those
Yeah.
also seem to work very well for anecdotally for many patients, and they
Yeah.
get benefits without having such good numbers of the GKI. So as I said, it's this whole overall metabolic switch or transformation. So
Yeah.
your inflammation is low, your insulin is low, and you can achieve that with different dietary approaches.
hmm One area that I was interested in is lactate, which is actually considered an oncometabolite. And now we do have the tools I have a lactate meter by my desk here, and I've measured it. And do you think I have different oncologists interested in the application of measuring lactate in cancer patients? Because lactate does increase with tumor burden. And as patients get better, lactate goes down. But we don't really talk about that much. So I'm thinking like a continuous lactate monitor or just use an off-the-shelf kind of point of care meter for lactate. So I wanted to get your opinion about that.
Yeah, so maybe I'm not as familiar with that. So what we would need, I guess, to corroborate is whether it correlates and associates with the different levels that you might have. I think they might
Mhm.
be quite more influenced by, for example, exercise. I think can produce much more lactate
Acutely, yeah.
acutely than the
Mhm.
tumor itself. And within different studies looking at lactate exclusion from the tumor, it is usually taken up very quickly by the adjacent cells. So I think if you have a tumor that is so big that it makes so much lactate that it spills to the blood,
For a
which has
brain
been observed
tumor. Yeah, yeah,
for brain tumor, then I think you can track it through different, you can do an MRI, you will be able to see it much better. If you have very small tumor, I am not super sure, maybe you can correct me, if you would be able to detect that, measuring the whole, blood lactate. Uh, but perhaps for the other aspects of metabolic efficiency of like your normal cells, perhaps it would be a good measurement to include together with glucose and ketones. Uh,
yeah,
I would love to be able to measure insulin through a finger prick or some of
yeah.
these things, but I don't know how that technology is coming along.
Mhm. I have some kits here actually at home, but you gotta, prick your finger and send it to the lab.
Oh, okay.
So, yeah, I wanted to. I know we don't have a whole lot of time left and we have to finish up, but I have a whole bunch of studies or questions relating to some studies on glutamine. But before we finish, maybe your thoughts on targeting glutamine and how patients. So we talked a lot about targeting glucose, some strategies, the importance of the GKI, but the GKI is not indicative of our glutamine levels. But one can predict that if you're moderating protein, glutamine's going to go down. So we have the drug Dawn, I get quite a lot of questions about, but also things like EGCG and sodium phenylbutyrate. So maybe
Yeah.
some quick comments about targeting glutamine.
Uh, yeah, so maybe if I could step back, so in the different steps that we decided for ketogenic metabolic therapy, so you would first diagnose the tumor in this case, let's say it's a GBM. Um, I think it's also very important to have a discussion with the primary treating physician of what other strategies might be implemented. Then after that, and also looking at the standard of care outcomes, which is sometimes that we don't put enough emphasis on. There is tumors out there that have so good results with surgery or a little bit of surgery and then maybe radiation locally or some adjuvant chemotherapy that you can still do ketogenic metabolic therapy, but maybe you don't have to bring in all drugs or repurposed drugs or metabolic inhibitors. So for those tumors, maybe you don't have to consider it, but for aggressive metastatic tumors and GBM, which is not metastatic. Well, it does it does metastasize, but it's kind of trapped in the brain. So for those where you know standard of care, and I would always encourage to look at the long-term outcomes. So long-term meaning 10 years survival, not 5 years, not even 2 years. Really looking at, because that's what people understand when you say can I get cured or can I survive this cancer? What is the treatment options? They don't want to know about, you know, median overall survival, progression-free survival, all these metrics that you would use in a clinical trial because none of the therapies are working. So you try to make it easier for the companies to approve the drugs, you know, whatever. But the patient really cares about long-term survival. So I would ask for a GBM, what are my chances of long-term 10-year survival? And the chances are 0.8%. So in that circumstance, I think that also puts, if you have this discussion with the oncologist, that puts, you know, a little bit more empathy and understanding. Okay, I want to try, and you know, they know, everybody knows, and clinical trials are encouraged in GBM. Uh, but also, I think this falls on the patients themselves a little bit to understand and to play doctor a little bit and to sit down. And I know it's very stressful, but you really need to take care of your own kind of journey if you are dealing with some of these very aggressive tumors. And then you would bring in, you know, you would do like a health assessment to know what your baseline is. And then you would initiate dietary ketogenic metabolic therapy
Mhm.
to make this switch in your metabolism that would make it possible for metabolic targeting. And then you would bring in standard of care, or in my mind, we would bring in drugs to target glycolysis and glutaminolysis, as you said, to target
Yeah.
glutamine metabolism. With diet itself, it's not as easy to. So the only things that I found that might influence glutamine metabolism from the lifestyle interventions would be either a 14-day fast. Cahill, I think Aoki, one of his collaborators, did like a 14-day fast,
Yep. Yep.
and
Yep.
they saw that glutamine starts to go down. They actually
Yep.
used sodium phenylbutyrate, I believe, at the end to even lower it a little more to see what happened. Um, so that's apparently safe and possible. So that is an option. Although I don't think most people would find that
Hmm.
something pleasurable. Or like high intensity exercise
Mhm.
also transiently can do a drop in glutamine availability, but doesn't
Yeah.
really target glutamine utilization. It's just less glutamine in the blood. So for glutaminolysis, you really need to bring in drugs.
Mhm.
The 6-deoxy-5-oxyamynoleucine, DON, which is kind of old drug, I believe from the 50s. It's a glutamine analog. It basically blocks all the enzymes that use glutamine as a cofactor. So it's glutaminase, which is
Mhm.
part of the glutaminolysis pathway, but also, you know, some nucleotide synthesis and purine synthesis and other things. So that seems to be a very effective drug in targeting glutamine metabolism. Problem is, it was abandoned in clinical trials. So the development, actually, the NCI was doing some of the development. Uh, I personally do not believe, compared to other chemotherapies, it is toxic. People always say, well, it might be toxic. I don't think it's toxic. Um, when used at reasonable doses and in a pulsed manner. Uh,
Pulse. Yeah.
but it is not available for you cannot just prescribe it as a physician. So
Yeah.
there's a little bit of conflict there that we need to still develop more. Uh, some of these other glutamine antagonists like CB839
Mhm.
or DRB104, which is basically the same thing as DON, really, but it's just this for IP IP
Yeah.
protection. That they are in clinical trials. We don't have a clinical trial for this. It's John Hopkins and a different company.
Mhm.
So when these get approved, maybe it will be much easier to
Mhm.
target glutamine metabolism. The things that you can do is perhaps sodium phenylbutyrate, which really lowers the glutamine availability. So you basically, you excrete in the urine
Excretion.
glutamine,
Yeah. Mhm.
or L-asparaginase, or some of these some of the repurposed drugs supposedly have an inhibition of glutamine metabolism, like
Yeah.
sulfasalazine, tamoxifen, apomorphine, and a couple
Mhm.
of others. Um, so those might be also
Okay.
used in conjunction with.
In more of a press fashion. So, what I'm getting,
Mhm.
what I hear you saying is like maybe sodium phenylbutyrate, which is sold as butanol, is pretty safe. Like I've taken it. Actually, it has a mild glucose lowering effect too. So maybe sodium phenylbutyrate, EGCG extract, maybe inhibits glutaminase a little bit. Maybe the jury's still out, but there's some. And then with Dawn, so I really want to focus on things that are readily like people can get. And I know the accessibility to Dawn is a problem, but
Yeah.
if that is used to use it in a pulsing manner, but it's also going to cripple your immune system during that period of time. And then you let your immune system recover, pick up and clear out the carcasses of the dead cancer cells, and then pulse it again for 1 week, 3 weeks later. So that's in my mind, if I was going to do something, someone that I love, like, in a protocol, it would be like to pulse it in a conservative way. Because I know Dawn can cause some GI issues and
Yeah,
communicated with me about
for
four
sure.
people that used it. Mhm.
Correct. I mean, we
Yeah.
also do. So GI issues for sure, and some nausea and mucositis can appear.
Mhm.
I think the form of administration is also a problem.
Mhm.
Anecdotally, we can say people have taken it orally, but really you would have to do, subcutaneous or
Yeah.
intramuscular. IV is ideal, but might be difficult
Mhm.
in kind of empirical settings. But I would disagree that it cripples the immune system. That might be a little too strong of
Dose
a
dependent. Yeah. Uh-huh. Yeah.
descriptor. Yeah, if I think if you use it in a pulse manner and you allow time to recover, even the pulse itself, it doesn't like
Transient inhibition. Yeah, maybe.
transient inhibition of
Yeah.
of the function, but it doesn't usually cause like a myelosuppression like you see for some
Mhm.
other drugs that really
Yeah.
like
Nothing
your
like
white
chemo.
blood cells are like zero, and you have to
Yep.
use like these stimulants to make your bone
Mhm.
marrow work more. Yes, if you use it continuously, if you did an infusion every day, as they did in some of those older trials,
Mhm.
uh, then yes, you get some more of these side effects that would need to be managed. And I would like to remind people that Dawn is a chemotherapy technically. So people
Yeah.
when people say use ketogenic metabolic therapy or metabolic therapy and it's non-toxic, I would say it's minimally toxic or it's designed with the primary objective of being as little toxic as possible. Uh, but if you start bringing even repurposed drugs as sodium phenylbutyrate or dichloroacetate or mebendazole,
Mhm.
which we might talk about later on, uh, these all have like a risk benefit profile that you would need to consider before you prescribe them or before you take them. Which logically, even the diet, I'm sure there is someone out there that got like hypotension and they fell
Mhm.
and maybe they injured themselves if you don't supplement correctly with electrolytes. So all these things always putting in perspective of standard of care, it's very well managed because it's so standardized that there has been no advancement in my mind. There has been no advancement in like new chemotherapies or new approaches,
Mhm.
but the management of the side effects is so good
Yeah.
that you can really get through it. And hey, if it works, that's fine. But for some of those tumors where it doesn't work, you need to bring in. Unfortunately, you need to kind of learn as a patient, and you need to bring in some of these other things, and it takes time. So like people
Mhm.
also they want a GKI of 1 the second day after starting the ketogenic diet, and these
Yeah.
things take like months to get into like an optimal state. I don't know out of the top of my head. I know for like complete fasting you need at least 72 hours uh, to to have the metabolomic kind of changes that you observe for fasting. I
Mhm.
imagine for like a ketogenic diet, for the upregulation of all the transporters and the gene expression, and for every single cell in your body to kind of get the memo that now this is the primary, change in fuel. That might probably take weeks to
Yeah.
months, I would say. So these things take time. So that allows, in my mind, that's actually a good thing because that allows the patient uh, as long as they have the time, of course. If not, they have to do like accelerated learning
Mhm.
transition. But if they have a little bit of time, they can initiate this and learn about it during the first
Mhm.
month, which is like a trial period. Um, and then get good at optimizing. So first you have to learn, and then you would optimize your numbers. You cannot
Yeah.
optimize your numbers where you're still just trying to figure out how many carbohydrates are in a broccoli or
It's
something like that.
hard, yeah. But the more you do it, the easier it gets and the more efficacious it gets over time because you learn how to adjust your GKI. I do think that creating a very severe energy deficit right out of the gate can be in and of itself toxic because to your muscle tissue, for one thing. But even though ketones have an anti-catabolic effect, but the energy deficit and caloric deficit could also impair like immune function. So I have so many questions I want to get into, but in particular, like redox therapies as it relates to hyperbaric oxygen, ivermectin, mebendazole, all these things. I got like 200 questions, but that's definitely going to be a part two. But I
Yeah.
thought, I mean, this overview was great, Tomas. We really appreciate your knowledge and expertise and wisdom kind of in this really important topic, that I think could revolutionize the standard of care for glioblastoma, especially, the article that you were first author on had what, like 49 authors on it, and including
Correct. Yes.
neuro-oncologists. And yeah, so
Yeah, we try to pull everyone together to because it's also frustrating. I mean, I sympathize. I understand it's very frustrating for the patients because there was not like a central paper that they could go to, and these many of these
Mhm.
things even that we discussed today, I think we'll have to do the part
Yeah.
two, because I think people will also frustrated. Well, he didn't tell how much ivermectin should I take, or what should I eat, what do you know.
There'll be a lot of questions. We'll compile them, and it might be
Correct.
a part three too. But I want to go
Correct.
deep into, like there is supplementary. So for people who can access
Okay, yeah.
this, it's open access clinical framework for ketogenic metabolic therapy and glioblastoma. But I'd also encourage people to get the supplementary
Yeah.
data, because there's a massive amount of information in the supplementary
So I
files
think
and
what
dosages and
correct.
everything there too.
What they would find, what most people would find interesting, I think, is I think file supplementary file two. I did like this Excel sheets that allows you to calculate your macronutrients, and we'll get maybe into that next time. But how to initiate a ketogenic diet, and we are very happy to answer all the questions,
Mhm.
even if they have been asked many times. Uh, so also you can email me, or you can email that Seyfried, and we'll get some information your way, and take it one step at a time. These things are, as they are not as standardized as we would like to in this paper, a little bit more standardized, still very open-ended.
Yeah.
We don't have, people would love to hear exactly the steps that you would use to get a good outcome. We don't have them, but also the standard of care doesn't have them. So we believe
Yeah.
this approach is, as I said, is better than standard of care alone, and is better than doing nothing. So I think they
Mhm.
can be either combined, or depending on the tumor, you have to make some decisions, like radiotherapy to the brain might have some qualifiers that need to be discussed. And uh, I also understand the frustration. Like, this is not written for in a language that patients would like it to be written in. It doesn't like
Mhm.
give you, okay, step number one, do this, step number two, do that. It's more like a directs you to the other references in the field
Mhm.
that can give you more information. But if you have patients and you go to the references, you can find, for example, even menus for some of the clinical trials, like Hagihara, I think, this Japanese group. They did a very, very good, like, in their supplementary, there's like a menu with foods that you can eat, and so you can find the information. You just have to be a little bit patient to go through to the references, and to see what this directs you to the broader literature, and to see what others have done, and kind of bring it all together, and build your own approach.
Yeah.
That's kind of where we are right now.
That's a great point. Yeah, I think this review is like at least five reviews in one. I mean, I think it started ended up like 200 pages, and
Yeah,
so
it's
I was
it's
like,
been framed
you're
as a
never going to get
debate.
this
So
published, but
it's
you
been framed as a
did.
debate. So
Congratulations.
I think yeah. So they didn't want it as a review. So it's more like a debate. Oh, I also encourage people to read the peer review. Especially,
Mhm.
like, my idea with this was, hopefully patients could print it out and bring it to their physician, either general physician or their oncologist, depending on how busy they are. They may or may not read it.
Yeah.
But in the peer review reports, which are also included in the paper, I included even more information,
Yeah.
because some of the questions, the typical questions like you asked today, like, what about other fuels? What about ketone body oxidation? All these things. What about the clinical trials? Where are they? How are we going to do them? So all these things are addressed there too. So it's even more more information for those who want to geek out and dig in and read it. So I would maybe also, for if you are printing this out, bringing it to your physician, you could also print out the peer review notes and many of the questions that they will immediately have, like, well, what about the Warburg effect in cancer and some of these things, they are answered there too. So I think that should be a useful tool for resource for patients to have.
Yep. Well, thank you for doing that work. I know it was a tremendous effort. It was a bit of a team effort, collaborative effort, but you absolutely spearheaded it and did, the huge heavy lifting to get that thing published. So thank you. How can people find you and reach out to you? Are you on social? Do you have a website set up?
Yeah, I'm on Instagram, although I don't post that many things in general. I do have a website, so I do have like a consultation thing, or I had rather when I had more time. Right now, I think it would be more to I made like a forum also, like a Patreon, that if people want to support me personally, they can do that. I would also encourage people to support the research that we do at the Seyfried lab. So either Googling my name or Googling Dr. Seyfried, Thomas Seyfried name, you can also donate to the lab to keep us going. And I'm available to answer any email or question. Sometimes I apologize in advance. Takes me a little bit of time to get to all the emails, but I do to get to all of them, and I'm happy to share information with anyone that wants to kind of embark on this and include it in their approach to disease management.
Well, great. Well, thank you so much for this review article, for all the work you're doing in the lab, for taking time out of the lab to do this educational outreach, podcast with us. And I really look forward to part 2. So I'm gonna, or maybe even part 3 too.
Awesome. All right.
Thanks again for joining us.
All right, Dominic. Thank you. Thank you so much.
Thanks for listening to this episode of the Metabolic Link. I hope you enjoyed that incredible interview with Dr. Dominic D'Agostino and Dr. Tomás Duraj. Really, he's on the forefront of cancer research, especially as a metabolic disease. We actually have a live Q&A coming up with Dr. Tomás Duraj. That's coming up on February 27th at 8 a.m. MST, 10 a.m. EST. Definitely go over and sign up for that. That's that's membership.metabolicinitiative.com/Duraj, DURAJ. That's DURAJ, membership.metabolicinitiative.com/DURAJ. And I hope you'll join us on February 27th, 10 a.m. at EST, because you'll be able to ask him all of your questions about this episode and the latest research on cancer as a metabolic disease. Until next time, we'll see you guys soon.
Love learning about metabolic health? So do we. It's why we created the Metabolic Initiative, an online educational platform providing evidence-based education on metabolic health and therapies for healthcare professionals and the general public. By joining the Metabolic Initiative, you'll gain access to hundreds of expert lectures, interviews, panel discussions, and even private episodes of the Metabolic Link. CMEs are available. Go to metabolicinitiative.com to get started. And as always, thank you for listening to the Metabolic Link.